Hello everyone. On behalf of the PHRN, I'd like to welcome you to the first Linkage Luminaries webinar for 2022. My name's Felicity Flack and I'm the Manager of Policy and Client Services at the PHRN. I'd like to begin by acknowledging that I'm talking to you from the lands of the Whadjuk people of the Noongar Nation, and I'd also like to acknowledge the traditional custodians of all the lands we're meeting on today and pay my respects to elders past and present. First of all, just a little bit of housekeeping. If you've got any questions for today's speakers, please type them in the Q&A box, and you can do that at any time during the presentation, and we'll answer as many questions as possible after the presentation. This webinar is being recorded, and we will email you as soon as it's available on the PHRN YouTube channel. So let's get to our speakers for today. I'm absolutely delighted to introduce Dominique Cadilhac from the Florey Institute for Neuroscience and Mental Health and Monique Kilkenny from Monash University. Dominique and Monique are old friends of the PHRN as they were involved in one of the very early cross-jurisdictional linkage projects with a clinical registry, the Australian Stroke Clinical Registry. And I hope you'll all be interested to hear about their work over many years now using linked data in stroke research. So thank you and welcome to Dominique and Monique. Now I'm going to stop sharing and hand over to Monique. There we go. And we should be all ready to go. Have you got that, Monique?
Well, thank you so much, Felicity, for that warm introduction and for asking us to speak today. It's a great pleasure of ours to really highlight the way in which stroke data linkage associated with the Australian Stroke Clinical Registry has progressed over the last 10 years. Oops, sorry. So I'm just, we've split the talk in two parts, so nice and even, 5 and 5. So I'll be just covering off some of the, really the background, but some of the work that we've done in particular around the acute stroke care and management, and Monique will be covering off some of the aspects of care in the community. So look, we've been fortunate that we've highlighted the way in which stroke data can be maximised to really understand that whole patient journey from prevention, treatment, through to longer term outcomes. And that has been reported in a paper by David Ung, where this information is readily available to you in the journal Stroke. But the concept is that when you look specifically at a stroke event, so someone that's come to hospital that's had a stroke and their data is included in a registry like OSCAR, rather than asking the hospital clinicians to collect more data, we can use data linkage techniques to look backwards at what happened to the person prior to their stroke, and also look forward to see what their ongoing journey has been like and their outcomes from that. So these are the sorts of things that we will be illustrating today in terms of what we've been unpacking in each of these parts. I just will provide an overview of the Australian Stroke Clinical Registry. It was established in 2009 with some grant funding, mainly from the Safety and Quality Commission. And then we have subsequently been able to continue to support that and grow it across the country. So 63 hospitals are currently contributing data. We've got, over 160,000 episodes of care. We've collected outcome data on nearly 60,000 people that have completed our patient-reported outcome surveys. We include consecutive cases with stroke or transient ischemic attack if they've been admitted, and it's a minimum data set on all consecutive patients. We use an opt-out approach, so we avoid selection bias, and we're collecting the data in an integrated stroke data management system that was supported by the Stroke Foundation to implement, so that when we collect data for the registry, when we do a much deeper dive into national data for adherence to clinical guidelines, which is led as an audit program by the Stroke Foundation in a smaller subset per hospital, any data that's contributed by our OSCOC participating hospitals that overlaps with anything in the audit is automatically pre-filled. So that means we're not asking clinicians to collect data more than once for the same variables on the same patients. And this is really the way in which we have to go, because the data collection burden is one of the main barriers to participating in clinical quality registries. Our follow-up data is a single survey between 90 and 180 days after the person leaves hospital. The value of doing this, even though it's a lot of extra work and effort, because we have to get ethics and permission and put in a lot of privacy preserving principles, is that we do have really good personal information like name, surname, dates of birth that allow us to reliably link with other data sets, and also contact these people by mail to collect information about where they're currently living, have they been readmitted to hospital, their disability status, which is collected by the modified Rankin scale, their current quality of life, and we don't limit our cohort to only adults, we include children as well, so we have age appropriate quality of life measures for those children. So over the last 10 years, we've worked really hard to integrate what we call the National Data Platform for Stroke, and Monique oversees this at Monash University in partnership with us. The reason why we separate roles is that Monique's team don't have access to any personal identifiers, and that's really important, but it also means when they analyse the data at an individual hospital level, they're unaware of the site, so they have no preconceived biases in terms of the performance of those sites or how they treat their patients. So it is really an important separation rule in sharing responsibilities for operational activities of a registry, and then how the data are collected and curated and maintained in a de-identified format, both at the health service level and patient level. We've had a number of projects that have provided seed funds for us to do linkage with different entities, mainly with Ambulance Victoria. We've been able to link data on ambulance records. The Stroke 123 project was our first inception project around linking with emergency admitted episodes in different jurisdictions and hospital admitted episodes. And then there's been newer initiatives looking at linking with the PBS and MBS. So this is illustrating how we have information across the whole patient journey that feed up into our data linkage program. This is just an example of how we've used data from the initial, sorry, it's a bit touchy, Stroke 123 project. So our first linkage with this was with the National Death Index, and that allowed us to look at survival over the longer term and have confidence that we captured all that data on people who are alive or who had died up to 6 months after their stroke. So this is an example here of people being prescribed antihypertensive medication before leaving hospital, which is part of our stroke clinical guidelines. And the hazard of death is reduced by about 23% compared to people who are not discharged on these medications, because antihypertensives are very important in preventing future events. And if you have another event, you're more likely to die from that event. The other way in which we've used the data, looking at the death data, is to explore differences between hospitals in metropolitan areas versus urban areas. We've looked at whether or not they've had best practice care and whether or not this has influenced survival. And one of the main, this was a partnership with the University of Tasmania. And we found that that despite significant differences in indicators of stroke quality of care, patients treated in regional hospitals had similar quality of life and survival. So although there were these differences in access to some of these treatments. The longer term survival was not impacted. But we also then have that question as well, they may have survived their stroke, but was their disability worse? So this is where having the patient reported outcome measures and quality of life information really helps to then value add to this story. More recently, we've used our data that's collected in a continuous way to unpack the issues for the COVID-19 pandemic. And the way in which we did that was to use matched data from 61 hospitals that contributed data in the year prior to the pandemic and then in the first year. And we used interrupted time series analyses to look at trends and use the interruption points were when the first wave started, so when we had the first death recorded, and then during the second wave of the pandemic. And we adjusted for things like seasonality, number of episodes per week by stroke type, because these are things that could have potentially also influenced our data and results. And this is what we were able to show. And of concern to us in the field is that treatment in stroke units decreased during the pandemic period. And this means that people that aren't getting access to stroke specialists are not going to have the same outcomes, and they're certainly not going to get the same evidence-based care. The other concern that was highlighted from these data were that door-to-needle times for people eligible to be treated in emergency departments with drugs that help undissolve blood clots that are causing the stroke had also become longer. So it's taking longer. And now there's explanations for that because of the extra screening procedures and things in the way in which care pathways have changed within emergency departments. But it's still something we really need to keep our eye on, and it's something that we need to be working with and feeding back up to government and hospitals in terms of preserving best practice care for stroke when we know that the outcome will mean more deaths or more disability in the community if they're not receiving the most appropriate care. The other thing that we're thinking about in terms of future opportunities is what it means. So COVID-19, people that experience COVID-19 have had problems with an increased incidence of stroke. And this is an area where if we could link stroke data to vaccination information, or in fact case data on COVID-19, and we could really unpack for Australia what the impact on the increased risk of stroke has been. So this is some of the work that we're thinking about, as well as the longer term impacts on neurological conditions, which is emerging as another consequence of COVID-19. Some of the work we've done in the pre-hospital space using the ambulance data has been to link with national death registrations, the Ambulance Victoria data, and also the admissions and ED presentation data. And having this richness of overlapping information has really highlighted some issues, not only within the OSCA registry with the variable for use of ambulances, but also sometimes we had patchy data in the ambulance clinical records, which is their data, and also we were able to validate some information from the ED administrative data. So it not only is it useful to have multiple data sets to enrich the information of individual patients, but you can also use it to cross-validate the information that you have. So we've been able to look at things like the sensitivity or the accuracy of the dispatch callers, and also the paramedic assessment of people with stroke, because we've been able to sort of take information like pre-hospital processes of care and then have an understanding of what that has meant before they got to hospital, and then consequently the downstream effects of someone with confirmed stroke, whether or not they were identified as having a stroke in the pre-hospital setting, and what that meant for them getting definitive care such as thrombolysis or access to stroke units and things like that, and what kind of time delays are involved. This is part of a PhD project, but What we found, just a high-level summary, is that there are differences in the types of people that will take ambulance and the types of stroke that are experienced. 81% are dispatched with lights and sirens, so that's really good because that is part of our clinical guideline, and that the majority of these patients that take in an ambulance are those that reside in metropolitan areas. So there's something interesting there that we need to consider about public awareness and education, potentially about using an ambulance if you suspect stroke, and that again, similarly with public education, because so few of them arrive to hospital under 6 hours, that again supports the need for public education about what to do and getting to hospital early. Some of the case time metrics that we've pulled out are identified here about people getting to hospital faster if they're notified in advance of coming to hospital, and also whether or not the screening tool for suspected stroke has been used. We found that 7 minutes overall in the case time was reduced if ambulance officers had, or paramedics had, used this tool and recognised a stroke. Moving on from the pre-hospital data linkage work that we've been doing is the acute care hospital processes through our Stroke 123 project, and there's quite a few papers now emerging from this. So in this study that was funded by the NHMRC, we linked data from 40 hospitals with we had over 15,000 patients, and we linked that to emergency department records and admission records, and it took us about 18 months pretty much for each jurisdiction to enable us to get the data. So pretty much by the end of the 4-year study, we were ready to start analysing it. So you have to be very patient, but I think more and more as these data linkage studies are breaking ground, we're getting faster, more efficient processes working with data linkage units. So I just don't know why it's not moving. So here we've identified using the linked data that if people came by ambulance, they're 3 times more likely to receive thrombolysis if they had an ischemic stroke, and also if frail older patients were also more likely to come by ambulance. So we wouldn't have been able to qualify or quantify people as frail without having had all the comorbidity information from the emergency department and admitted episodes records for us to work some of this information out. Then we also were able to identify for patients not treated in a stroke unit that they were at greater risk of developing a chest infection after stroke, which is, a serious complication of stroke, and we were able to explore factors that we didn't have in our registry. So we don't collect any information on ICU, but you can see here that there's a strong relationship as one of the key drivers. So patients admitted to intensive care are 8 times more likely to develop a chest infection. So these additional data really help us to understand the cohort, the patient journeys, as well as the fact that it can guide policy and practice in terms of how we avoid these complications of stroke too. And if there are more certain types of patients where we have to be more vigilant. This is an example of where we've looked at antihypertensive prescription after stroke related to age and comorbidities. Here, what we found was that younger patients with fewer comorbidities were less likely to be prescribed antihypertensives compared to older patients with comparable comorbidities. So again, there's some clinical information and messages here about why it is that younger people are not being prescribed these medications, even though that goes against best practice guidance. In some work that Monique has done looking at why people get readmitted and what are the factors associated with 90-day readmission. So what has been found is that 85% are more likely to be readmitted within 90 days of discharge from acute care, And some of the factors that influence this, in particular, is their ability to walk on admission, which is a proxy for stroke severity that we collect in the registry, but it's not collected in administrative data. So it would have been very difficult to find factors like this if we'd only relied on administrative data. And for patients discharged to inpatient rehabilitation after acute stroke, we found that they were less likely to be readmitted. So for us, we really try and understand, why is it that people that go home straight after their stroke, and the length of stay on average is about 5 days, why is it that they are bouncing back? And why is it that if you have or offered inpatient rehabilitation, that you're less likely to come back to hospital? And, again, this really can be telling, and being able to link our data to other sources of information like the Australian Rehabilitation Outcomes Centre data can help us understand maybe what practices were different or offered differently, or what features of patients means that they're less likely to be readmitted. So in other areas of where we've used the data, as I mentioned before, there's been some work on developing a frailty risk score. And the reason why we've done this is because many of the standard, like the Charlson Comorbidity Index, don't necessarily include all the factors that are probably relevant to people with stroke based on their demographic and clinical characteristics. So we undertook this piece of work in conjunction with one of the postdocs from the University of Tasmania, Huang, to really understand whether or not this would be an appropriate risk score to use in our population. And this really relies on us having that ICD-10 coded comorbidity data, rather than asking our hospital clinicians to collect all that information that would go into that type of index, because it actually has quite a large number of measures. But what we have found is that this is more relevant in terms of the variables, but also more useful for us in ensuring we're covering off important measures as part of our multivariable models for this for the types of analyses that we do, so that we're taking into account a number of potentially confounding factors, including whether or not people have cognitive impairment, which is one of the additional variables that are used in this score, rather than the more standard scores that are more prognostic for whether or not people survive. So I'm going to hand over now to Monique to cover off some of the other work we've done.
Thanks, Dominique. That's brilliant. So I'm going to give you a summary of all the work we've done over the last 10 years. Dominique's already summarised the work we've done in relation to the ambulance, understanding ambulance arrival prior to stroke, as well as the acute care processes. And I'll also give you a summary of some of the work we've done, what's actually happened after the acute hospital episode, rehab care, as well as what's happening in general practice. And we'll also give you a summary of a paper where we looked at the allure of big data and outcomes, which summarises a lot of the work that we've undertaken over the last 10 years. So just getting back to Dominique's prior presentation, in Stroke 123, we also undertook a project where we compared the clinical diagnosis with the administrative data. And what we found with that was that there was differences. So if you have a look in the table there, you see that the false negatives, we found around about 2,500 false negatives. And of those, instead of being coded as an ischemic stroke, it was coded as unspecified, or I-64. We didn't understand whether it was an ischemic or hemorrhagic stroke, and that's really important in stroke, that we understand which type of stroke it is, because there's different treatments. And 10% were coded as a transient ischemic attack. So that's an example of the stroke 1, 2, 3 data that we use to look at coding. And as subsequently from this work, we got a little bit of funding to develop an education program. This program's been developed with the Australian and New Zealand Stroke Coding Working Group, and this is happening over the next 3 months. And unbeknown to myself, the need is huge. I've got nearly 260 people attending this presentation next week from Victoria and Tasmania to understand coding. And so the coding session is not just about coding, it's also about clinical documentation. So if their clinical documentation is not there, the coders can't code it. And so the coding session will go through the rationale for coding of stroke, understanding of the brain and stroke and the treatments, which will be presented by neurologist Lauren Sanders. And then we'll go through all the standards for coding stroke, good coding practices, the coding trees, and clinical documentation. And hopefully this will be rolled out also to clinicians so there will be interchange between the coders and the clinicians to ensure that they're documenting correctly and the coders are coding correctly as well. So we'll monitor this over the next few years to see whether we improve the coding over time. So just the first section I'm going to speak to you about is general practice. So there's been a number of studies we undertaken. The first I'm going to speak to you about is GP stroke. And in this project, we linked the Australian Stroke Clinical Registry with PBS and MBS data in Western Australia, Queensland, New South Wales, Victoria, and Tasmania, as you can see in the slide here. And so one of the projects that I was really keen to understand is the initiation, adherence, and discontinuation of medication. We didn't really understand what was actually happening out in the community. We knew that patients were being discharged with this medication, but we didn't understand whether they were continuing with these medications. So we've looked at antihypertensive medications, lipid-lowering medications, and antithrombotics. So you can see here we can look at the new users, which is the incident users. So after stroke, a lot of patients were new users for antithrombotics, around about 60%. Around half the patients were new users to lipid-lowering, and about 20% are new users for antihypertensives. But more importantly, one of the important things we found in this paper, which was led by Lachlan Daly, one of my PhD students, is that up to 1/3 of patients discontinue the medications within 1 year. So that's a real problem, because it's really important that stroke patients continue the medications for the rest of their life. They need to be on these secondary prevention medications in order to prevent stroke. So we need some type of intervention to ensure these patients continue the medication. It's not just an infection, it's actually a stroke. So we're all looking at developing some type of education programs to improve the knowledge in the community for patients with stroke. Another project also done by Lachlan Daly, he looked at medication adherence and survival. So in the community, we always look at, is a patient adhering to the medication 80% of the time? It's either 80% or less, or 80% or more. So in this paper here, he looked at the greater adherence to medication improves survival. So you can see in the graphs here for antihypertensive statins and antithrombotics that increasing levels of medication adherence was associated with continuous reduction in all-cause mortality. So this is using the same data set as I mentioned before. So the next example was we got some seed funding, Jusip Kim got some seed funding from the Stroke Foundation, and this project was linking the Australian Stroke Clinical Registry to general practice data. So we've got access to data in Polar just for Victoria. So in this project, we understand that general practitioners are out in the community and are providing long-term management of stroke. They more so than neurologists. They tend to go there after you've had a stroke. You'll go to a neurologist once, and it's more likely that main role is the general practitioners in the community for management of stroke. And at the moment, there's limited evidence of understanding what the current management of stroke in general practice. And so what we found in the other studies, we knew that these patients were being dispensed these medications, but we didn't understand whether the GP was prescribing these medications. We didn't have any information also on what their blood pressure level was, what their lipid levels were. We didn't have anything on their pathology. So this was a great opportunity to understand a bit more about risk factor management, as well as whether they were being prescribed these medications. So these analyses were done by Monique Kilkenny, who's a postdoc within our group. And one of the interesting things we found with this analysis was that only 2 in 3 patients had the diagnosis of stroke or transient ischemic attack documented in the medical record or the hospital GP management system. And so we found that the portion of patients who had risk factor assessment increased. They're more likely to receive risk factor assessment if the documentation, the diagnosis was documented. You can see here around about within 1 year of hospital discharge, 85% of patients were assessed for blood pressure, around 50% for lipids, kidney function around about 1 in 2, and blood glucose just under 50%, and body weight as well. So that sort of shows you the difference between those who had the diagnosis documented and not documented. Looking at the review of active and prescription medications. So Monique Kilkenny did these analyses, and he looked at anticoagulants, lipid lowering, antihypertensives, antithrombotics, and antiplatelets. So you can see that there was really good, the GPs were doing a great job in reviewing active prescription of medications, but there was differences between those with a diagnosis documented or not. Looking at care planning and team care arrangement, these results are very similar to other work we've undertaken, and it shows that about 1 in 2 patients with stroke or transient ischemic attack are either receiving a chronic disease management plan or team care arrangement. Looking at attainment of risk factor targets within 12 months was another thing. We looked at all the patients, and we found that when we looked at glucose management, that 80% of the time for all the contacts, glucose was attained. Blood pressure management was about 80% as well, and lipid management, about 1 in 2 patients overall within 1 year had attained their lipid control, and similar, just under 40% was for weight management, and kidney functions were about 1 in 3. So when we looked at those patients with a diagnosis documented or not, we didn't actually find many differences between the risk factor attainment, except for lipid management. We found a difference between those who documented. So that was interesting results as well. So in conclusion, for this analysis, this is the first time we successfully linked data from the Australian Stroke Clinical Registry with general practice data. And it really provides us complementary information that we can't find in other data sets for understanding what was happening with the management of stroke in the community. And as I mentioned before, two out of 3 patients with stroke had the diagnosis documented in the POLAR records. And maybe in the future, what we need to do is do some type of regular sharing with the Australian Stroke Clinical Registry and general practice to facilitate sort of making sure that we have patient follow-up after discharged. So the next project was led by Associate Professor Nadine Andrew, and this is looking at chronic disease management plans. And this project involved the 2 states in Australia, Queensland and Victoria, and it was a very large data linkage project where we linked the Australian Stroke Clinical Registry, about 30,000 patients, linking not only the MBS and PBS, but also the admissions and emergency data sets, as well as linking to National Death Index and aged care data for the periods listed on the bottom of the slide. So the main aim of this project was to sort of understand the effectiveness of chronic disease management plans or primary care policies in Australia using stroke as a case study. And this is the protocol that was published in the International Journal of Population Data Science. So one of the things I just wanted to note is sort of the figure down below, which shows you how we define the control period and exposure and outcome period for this project. So we wanted to understand what was happening prior to their stroke. So the control period, we understood what were the hospital and emergency department contacts as well as the doctor contacts. Then we had the sort of the washout period, the 6 months, which included when the patient was admitted to acute care, as well as whether they were admitted to rehab. And then the exposure, we wanted to understand, were these patients, did they visit their doctor? Did they receive a chronic disease management plan? Did they adhere to their medications? And then we also wanted to look at the outcomes, whether they were readmitted and whether they survived after stroke. So at the moment, we've completed the analysis, and Nadine's writing up the primary paper, which was looking at the long-term health for survivors of stroke with and without a disability and the receipt of chronic disease management plans. And I've been looking at the adherence of secondary prevention medications for relation to chronic disease management plans. And Judith Kim will be looking at the cost effectiveness of these different models of primary care. So just relation to my particular project, what I did find was that the financial incentives or the chronic disease management plan was associated with improved adherence. So we found at 18 months to 36 months that patients were more likely to adhere to all 3 medications, antihypertensives, lipid lowering, and non-aspirin thrombotics as well. So these results are being written up at the moment, so do not copy or distribute at the moment. Just going back to this project was also done by Lachlan Daly. Well, as part of the PRECISE, we undertook a survey, and we wanted to find out from the survey, we asked the self-reported information on whether they were taking these 3 medications, antihypertensives, antithrombotics, and lipid lowering. And what Lockie did here was to compare what was recorded in the pharmaceutical claims data compared to what was the patient-reported medication use. And what was interesting here is that we can say that the pharmaceutical claims data can be used to infer medication use. So we had good to excellent sensitivity and specificity compared to the patient-reported data for medication use. So just briefly mention one other data linkage project, which Dominique mentioned before, where we linked the Australian Stroke Clinical Registry to AROC data, the Australasian Rehabilitation Outcomes Centre data. And this is a project that was undertaken by a clinician, Simon Malasky. And so we undertook the analysis and he wrote the paper, which was a great experience for him as part of the CRE. And what he found we linked the acute stroke episode, which is the registry, to the subacute, which is the rehabilitation, which is the AROC data, and then the follow-up is the OSCA follow-up data, where we collect the information at 90 to 180 days. And what he found that stroke survivors who achieved greater relative functional gain during their inpatient episode, during the rehab, had better quality of life, they reported a better quality of life, and also were more likely to report they were independent at follow-up. So I just wanted to also highlight to you a paper that was just published recently on the Allure of big data and stroke outcomes. And this project looked at the 5 Vs. So this is an infographic showing you the velocity, the volume, variety, velocity, and variability of big data. And it's really, the one thing I want to say that the volume is huge. So we managed to find 42 studies which are being published over the last couple of years, and the median sample size was over 10,000. And you know, 1 in 4 of the studies were over 50,000 subjects, so that was huge. And we had quite a, most of the studies were in high-income countries rather than low-income countries, so that's something we need to improve on. But the median time from data collection to publication was 6 years, so it was quite long. And I think we have that problem in Australia. It takes a long time for the data custodian process, as well as the ethics and receipt of the data, to undertake these analyses. So it would be good if we could improve the time from data collection to publication in the future. And there was real variability in not only the outcomes, but the data sources. Some were from the hospital, registry, mortality, and most of the outcomes were focused on mortality, less so than costs. So we need to undertake more studies looking at costs in the future. So that's a paper that, led by Mudine Alay, and it's just been published in current neurology and neurosciences reports. So as you can see, we've done a lot of work over the last 10 years, and we've had a lot of people to thank for. You know, more importantly, it's all the grants that we received as a group from the NHMRC, the Stroke Foundation, the Heart Foundation. So thank you very much. And recently, the MRFF. So this wouldn't be possible without all these funding groups. But also, more importantly, we need to thank all the students and the postdocs that, you know, wrangle this data and do the analysis and write these papers for our group with our supervision. So they've learnt a lot, and I've learnt a lot, and you keep learning. And more importantly, we've developed large collaborations nationally, but also we're developing collaborations internationally in this area. And also the support from the Stroke Foundation in this work needs to be acknowledged too. And in the future, hopefully, we will have a national data platform for stroke where we can have all these various sources into one data stream for stroke. So at the moment, we've got about 7 projects and 22 million records. And we've published 37 papers and 5 media reports. And one other thing I need to say, we've got a national stroke data linkage interest group. So if anyone's on the line who would like to understand, you know, data ethics or data custodian processes, or even analysis, we're a really friendly group. We meet 4 times a year, and we also have a virtual conference once a year, which is an option for PhD students and postdocs. And we're here to help because we've learnt a lot over the last 10 years, and I'm love to help people and make sure we pass on the knowledge that we've gained for this whole process for other researchers who are embarking on this for the first time in their career or as a PhD student. So this is the platform, and I'm the co-chair with Lee Nedkoff of the National Stroke Data Linkage Interest Group. And so just contact us if you want to be part of this group. And just to show you the massive data that is available for various research projects, that you can contact Dominique and myself if you've got an idea that you'd like to do as part of this project. You can do it. You don't have to be in Victoria. It can be interstate, because we've got various sort of data analysis tools now available that can they can analyze the data interstate. There's some media in relation to projects. And this is our group at Monash. So thanks to all the, and also thanks all to the patients and the hospital staff and Florey team for managing it. And this is the Florey team as well. And more importantly, the hospital staff and patients and all the consortium partners for the registry. Thank you.
Thank you. Thank you so much, Dominique and Monique. That was the most amazing summary of the fantastic work you've been doing over the last 10 years. I remember very well those early years when we first discussed the initial linkages, and you've come such a long way, and the depth and breadth of the work that you've been able to do is truly amazing, and I'm really proud that we've been able to highlight that today. So you're both very happy to answer some questions. So for our audience, if you've got questions for Dominique and Monique, please put them in the Q&A box, and we can answer as many as we possibly can in the next 10 to 15 minutes. But perhaps I'll start off while people just get their thoughts together, and just ask a question about what advice would you give people who are either wanting to set up a clinical registry or would like to include linked data in their existing registry? What are sort of key tips and tricks or advice to how people should approach it? Because you've learnt a lot over the last 10 years, I know.
I think the main thing is future-proofing the patient information sheet by having a statement that says, that makes it clear that the data may be linked with other data sets to understand people, you know, their health. So that's how we've got around that. And I'm sorry I forgot to put one of those slides in there, but that's one of the key, I guess, tips is that, you know, a few of the data linkage units have come back to us and said, what's in your consent form? Do you have consent? Are people aware? So it really helps to have that as part of the patient information sheet. Now, you can get a waiver, but it can make it more complicated and lengthy. So that would be my advice. And there are different examples now of wording that we can use to make that, you know, to show us examples. I know in Western Australia, they've also got some good examples of that from some of the work that's been done over there as well.
Anything you want to add, Monique? No, I think that's fine. Okay. It's definitely that information sheet and future proofing. It's the same with if you want to do this for clinical trials. It's really important, you know, in the future. I think we should be linking to all clinical trials. We spend a lot of money paying for these trials to be undertaken. We really want to understand, you know, the differences this medication or this treatment has in the future. So I think all clinical trials should be linked to, you know, survival data as well as medication or even hospital visit data to show the changes over time, not just the first year after.
So we have embedded that, Felicity, within our current clinical trials of discharge care and things like that, where people can tell us if they don't want their data linked to other records. And I think where that's really important is if one of your outcome, like a primary outcome measure for us is readmissions, and although we can rely on self-report, if the administrative data is going to provide more objective information, then that's where it's really helpful to have that additional data. The only downfall is that by the time you've recruited your participants and you send everything into a data linkage unit, and if it's a cross-jurisdictional project, it can be quite a time-consuming process to get the data back and have it analysed. So even if you include the data linkage costs in your grant, you might find that you're not actually, by the time you get to obtain the data, clean it, curate it, and all the rest of it, it might exceed the period that your grant funding covers. So wherever we can get slicker at doing this and working with data linkage units, and this is where we look to the PHRN for help in this space, the better, because it's really hard to fund the support and the analysis part, which is where all the grunt work really sits once a grant has ended its kind of lifespan. You then really rely on PhD students or postdocs that may be on fellowship funds and things, but even that's getting more difficult to obtain these days.
Well, we hear you, and we continue to do what we can to try and improve the situation. So, but let's get to some questions from the audience. The first one says, fantastic presentation. Can you comment on some of the potential reasons for the disagreement in the ICD-10 coding of stroke?
I think it's a combination of the coding, but also the clinical documentation. We need to make sure that the clinicians are on the discharge summary or the front sheet, putting the diagnosis, not CVA, and it's improving the documentation, but also educating the coders to, you know, look at the imaging results and seeing whether I can be more specific in my coding than when they're coding. So I think it's a combination of the reasons why there's disagreement is the documentation is incomplete, and also that the coders may not have taken the next step to look at more further into the medical record for more information, such as imaging, which 99% of patients with stroke have some type of imaging, either CT or MRI, so the information is there.
Okay. Next one. Were the impacts of COVID-19 on stroke care more pronounced in certain states? For example, those with more lockdowns. Also, were there any differences by hospital size or rural location?
So they're good questions. So yes, we compared what was happening in Victoria, which had many more lockdowns, and obviously the the impact of COVID was felt, especially in the first year of the pandemic. So there were differences, and we have presented that data back to government. I don't think we've looked at it yet by rural regional. So I can't answer that part, but yes, definitely. We use the rest of Australia as the I guess the prospective, what's going on now relative to Victoria. So it wasn't just a historical comparison, it was current versus, Victoria versus other, and we saw, some very worrying trends that were found even in the, comparing to the historical year. So that allowed us to do different types of analysis, looking at the same data in the same periods, but using the other states as like a control group, and then having a retrospective, a historical control group.
Next one's for Monique. How do you measure disability in the unpublished work you're doing?
So with the disability, we can use the modified Rankin scale. So we collect that at 90 to 180 days, which is self-reported. And we can also develop a sort of, in a way, disability using the frailty score, which is using the coded data. So we rely on the coded data to be correct in order to develop the frailty, or you can use the Towson comorbidity or the Alexa Hauser. So, that's about all we have. Is there anything else, Dominique?
I think that covers it off.
Yeah.
The next one is
just put the example. I put the example for one of the questions in the chat from John about the wording for the data linkage. It's just in the chat if anyone wants to look at that.
Great. Thank you. Next question says, thank you both for the great presentations. Just wondering, have you done some work on the long-term outcomes greater than 5 years following stroke hospitalisation?
So at this stage, most of the data sets, we don't have a large sample to do more than 5 years. But in the future, when we have the data platform, we'll be able to do analysis over time. But Dominique's just done some recent work looking at 10-year survival. So what was the sample size for that?
I don't remember those over the top of my head, but because we've had the National Death Index data continuously, like every year we link, and for every single person we update their death information. And the reason why we do that is because of that question about people saying whether or not they want to be contacted for further research. And 5 years down the track they may have died, or 10 years down the track they may have died. So we really don't want to be contacting people that have died. So we don't just do it for that current new cohort, we actually update the records on every single person. So that creates a natural long-term survival cohort where we can look at the change in survival after stroke and whether or not there has been the influence of the registry or better access to best practice care, if that's changed over time through participation in the registry, which helps in a way for us to better understand, mortality statistics and stroke and how they're changing, but also what the value of the registry might be as a case study. So this is a piece of work that we're hoping to write up. A University of Melbourne student kick-started it all off as part of her project last year.
So just to add to Dominique, so the main thing there for that, Peng, is that we can look at survival, but for medication adherence and for things like readmissions, we don't have the large enough cohorts to look at that over time. So that's something in the future I think would be important that we do a much longer cohort and time period, but we tend to mainly look at within the 1 year after stroke. And you also got to realise that the registry is only just on 12 years old. And you also, it's come cumulative. We started quite small, 9 hospitals, and as Dominique mentioned before, is 63 hospitals, and it's also increased over time. We've got support from Victoria and Queensland government support, so we have all, very good coverage of those hospitals, but it's sort of changed over time. So you've got to be careful of that as well.
It's all really interesting. Last question, I think. I think you've probably covered the ones in the chat mostly. So fantastic presentation. Congratulations on your amazing work. What's the consent rate for data linkage by the registry participants? For the students and postdocs analysing linked data, what kind of skills are required and training is provided? Okay, so two very different questions. We're going to start with the consent one. And
I'll answer the first and I'll hand over to Monique for the second one. So we have an opt-out, people opting out of the registry sits at around 2.3 to 2.5%. So it's under 3%. So that indicates to us that there's very strong acceptability of people's data being in a registry after they've had a stroke or TIA, but also that they're quite comfortable, because it's not a separate consent, it's all part of the one form. So if they were unhappy for us to hold their personal information for data linkage or any of the things that we use it for, then they would opt out, and it's a very, very low number. So, you know, work out what 2% is of 160,000, but we have a lot of records there, and you know, as Monique said, our sample sizes are cumulative, but if you compare, I mean, I think that they're all big samples, even if you're linking 5,000 people, because for you to obtain that data in any other way would be quite challenging. And then when you link their records, you get many thousands more records added to that. So it's very rich data. It can be messy data. So Monique will talk about the skills needed and the patience needed. But yes, I think, you know, it's reassuring that people are comfortable with the use of it, and the fact that we also really maintain our privacy preserving principles. And I think the fact that we have new instruments to store and securely access data, like through the SERP system, really will make it a lot easier for us to collaborate, you know, across with students and postdocs and researchers from different areas that have an interest in different components, because we certainly can't do it all.
So Monique, what sort of training and skills are you looking for?
So the type of training that they'll receive within our group is we have education sessions once a month, anything from data analysis to literature reviews. We also have scientific sessions once a month, so we're a very collaborative group. And so we've got a lot of resources in relation to this, where they will join the National Stroke Data Linkage Interest Group for more training, as well as there's wonderful courses around Australia by David Preen on linked data that they could do as part of their PhD. And more importantly is that we're a very collaborative group, and we're always learning from each other. And one of the things I've found, the more postdocs, more PhD students, we're always testing different ways to analyse the data, and it's always evolving and it's always changing and becoming better and better compared to how I did it clunky 10 years ago. So I think it's about the competitive edge of the students and the postdocs to get to join together to make it even better, which I just love to see. You just give them a nibble and then off they go. They're flying ahead. So we're a very collaborative organisation and really want to help each other. So the type of skills that you want is, for me, is all I want from a student is they try and that they persevere and they're determined. And, you know, we'll provide everything else. You just got to keep coming back with your questions. I don't care if it's dumb. I'm happy to help you. And I think that's the main thing. And keep smiling and keep having fun.
I guess if I could add to that, though, because I'm more of a pragmatist, epidemiology and biostatistics, and having a strong head for numbers, patterns within numbers, understanding coding. These codes can be quite complex. So you have to have patience, you have to have attention to detail, and you have to like unpacking a puzzle and being comfortable with sorting data and undertaking quantitative analysis. So it's not that you have to have done any multivariable statistics or things like that in the past, but at least have an understanding or the base introduction to biostatistics or epidemiology, because these are observational studies and you have to understand the characteristics of data, the distribution of the data, what sorts of statistical tests are appropriate for the data, and transformations and things like that, and what you do when you've got large numbers, because, you know, a 0.5% difference could be statistically significant but mean nothing from a clinical point of view. So it's also about not overstating what you might find, and really being able to collaborate with clinicians and others that can help interpret the data. And I guess just, you know, on a final point, because I know we're coming to the end of this, is really, you know, having an understanding of data quality. So big data can be complex, but it's also really understanding how well defined that data is, the data structure, but also the data dictionaries that sit behind it, because, you know, you don't want to be comparing apples with apples, and you don't want to be open to many of the criticisms you have for, you know, use of observational data and large data where you really don't understand how it came to be and what were the criteria for that variable being included or not included. And we found that, you know, especially with the ambulance data, which is more like clinical notes, that, you know, we've really had to work through quite carefully with the Ambulance Victoria team to understand what that data is, where it was derived, you know, how messy it is, how do we use it? How do we use it appropriately?
Okay, well, we've hit the end of our time. So I know there's one more question there, but I might put Francis in touch with you and you can answer him separately. Thank you so much to both of you. That was a just fantastic presentation, and it's clear that the audience have really enjoyed it as well. So thank you very, very much. I'm just going to share the screen, if Nicola will let me, to let people know about the next presentation that we have coming up. There we go. That's going to be go. I did that. So our next Linkage Luminaries webinar is on the 28th of April, and Professor Melissa Green from UNSW is going to talk about the New South Wales Child Development Study. So pop that in your diary if that's a topic of interest to you. And just everybody virtually give a great big round of applause to Monique and Dominique. Thank you very, very much. And we'll talk soon. Bye.
Thank you, and thanks everyone for listening.